Good evening, ma'am. Good evening, everyone.
Good evening, Mr. Kumar. Good evening.
We are starting with the Ganesh Vandana.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Good evening, everyone. Welcome to the today's episode, Dronacharya fourth episode. Over to you, Jyoti ma'am, for the today's webinar proceeding.
Hello.
Yes, ma'am, you are audible.
Good evening, everybody, and thank you each one for joining for this third episode of Dronacharya Speaks. And today we have our Dronacharya from J&K. And before we move on to listen to her, if we would be taking pearls of wisdom from our president of NIGF, Dr. Ragini Agarwal ma'am. And ma'am is now going to, on her way to Raipur, she is on the airport and still she has spared some time to be with us. रोशन जी मैम का एक शॉर्ट सीवी अगर हम डिस्प्ले करें रागिनी मैम का. Okay, so we will just, ma'am, I think Dr. Ragini ma'am has been the originator of so many forums. She has been a mentor guide to so many youngsters, and she is a name in not only North India, not only in the NIGF, but pan India. She has been the vice VP Foxy. We can see this busy slide of her CV, and sometimes I feel कि मैं पढ़ना कहाँ से शुरू करूँ और कहाँ खत्म करूँ, because ma'am has been the National Joint Secretary IMS, she has been National Convener, she has been founder of the Committee Chairperson Aesthetic Health, President Indian Society for Aesthetic, and I think we would need 5 more minutes to at least go through that CV. So, ma'am, over to you for your pearls of wisdom and to give us an insight on the program.
So, thank you so much, Jyoti, for your kind words. Very good evening to one and all, and welcome to our Dronacharya Speak program. First of all, I welcome Professor Indu Kaul on this platform. She is from Jammu Medical College, ex-professor from Jammu Medical College. Welcome, Induji. Friends, whatever we become in our life, it starts from the education given us, I can say the sanskar given us from the gurus. So guru is always very important. And why the Dronacharya? Dronacharya was the first guru which we can call a e-guru. First time somebody has become the e-guru. So we have taken this name because we are having the teachers with us from all the states, and we are going to learn something from their life, how they have gone through such a wonderful life and have a effect on so many students. So as Jyoti has said, I'm about to take a flight. Maybe I'll not with you all the time. Thank you so much. Over to you, Jyoti. But I'm there for 10 minutes.
Thank you, ma'am. Ma'am, I'll share my screen now so as to introduce our speaker, the lovely, beautiful speaker, Dr. Indu ma'am. So I will share my screen here. Yes. So, Dr. Indu ma'am is so just to a small introduction for ma'am before we listen to the guru. She's an eminent obstetrician gynecologist from Jammu with a distinguished career spanning more than 3 decades in clinical practice, medical education, women health care, and academic leadership. Her major professional achievements include her to be a member of the governing body of the AIMS Patna for nearly 8 years, a former professor head Department of Obs and Gynae Medical College, Jammu, where she has played a significant role in postgraduate teaching, clinical training, and upgrading the department and the advancements in women healthcare services. She has been the recognized specialist in high-risk pregnancy management, and she holds prestigious professional qualifications. She has been fellow of the Indian College of Obs and Gynae since 2016 and advisor to Jammu Obs Gynae Society, Indian Society of Assisted Reproduction, Jammu J&K, and advisor of the Gynae Oncology J&K. A member of many organizations and a postgraduate teaching, research, and scientific publications that we can see in this slide, that so many publications she has been doing and giving guidance to so many postgraduates. The training part she has also been undertaking all throughout her life. She has also herself trained into laparoscopy at the Ethicon Institutes and advanced laparohistro trainings at Minimally Invasive Surgery Center, Mumbai, and also trained surgeon for the laparoscopic ligation for the Department of Health 1992 to 99. Ma'am has been a trainer for training in the AIDS and HIV control program organized by Department of Family Welfare, Ministry of Health, Family Welfare, Government of India, and NACO in collaboration with UNICEF. At present, she is working as a chairperson of the Friends of GMC, an academician par excellence, a clinician, and a social contributor. She is known for her dignified leadership, empathetic approach, and a commitment to public welfare. She continues to inspire both the medical fraternity and the community. And here we can see her with Gyani Zail Singh ji, and also we can see her in the newspapers, in the talent show for special children. And these are the various other activities that we can see, the Jammu Obs Gynae Society activities, the workshops that she has been conducting, the Gynae Endocon, and so many. I think this is another very eminent gynec lab surgeon from Delhi, that she has been a social person throughout, and we can see in this beautiful picture so many beautiful and young faces, and I think she has been a mentor for so many of them. And here again we can see her with the VVIPs and the Wonder Womania 2019. And this is, I think, ma'am's daughter, who looks, I think, something very, very similar to her.
Yeah.
And I think we could make out, ma'am, from that. And again, so many other conferences, the Government Medical College, Srinagar, that has been her home, maybe, because most of the time she must have spent here. And again, we can see her doing these multiple academic activities. And so felicitations, and ISAR, the Jammu and J&K chapter that she had started. And we can here again see IFS people here. And again, Dr. Sudash, we can see here, and Dr. Pai sir and Dr. Rishma, I think they are starting the ISAR J&K chapter that Dr. Indu ma'am started. So multiple felicitations have been in her feather, in her cap, and she has been honored by so many at so many places. So I think here I stop sharing and I give it to her, because I think I will be taking her time, and I think we all wish to listen to her more than anything today. So over to you, ma'am, and so that we can listen to what your experience beyond the books, what you have learned over these years you wish to give us? Over to you, ma'am.
Thank you, Dr. Jyoti, for capturing milestones of my professional life in a beautiful manner. It's a matter of immense pride and gratitude for me for being invited for the prestigious honor of NIGF, New Incredible Gynaecological Forum. I really appreciate sincere efforts by the organizers for organizing such informative and meaningful sessions through NIGF Forum. I would like to congratulate Team NIGF for creating opportunities to share knowledge and exchange ideas on this platform. Before I begin, let me thank Dr. Shadda Jan, who is the patron of the organization. I can very well understanding how much hard work she must have put in her vision for just starting this NIGF program. And I thank all the team and the members and organizers, especially President-elect Dr. Ragini Agarwal. I'm going to miss her right now in this session, but I know work is work and work is worship, and that's what she's heading for. And who is the President-elect, and then Dr. Sudha Sharma, Secretary General, Dr. Jyoti Malik, Joint Secretary. I have known Dr. Ragini Agarwal for more than a decade. I'm a wonderful person, and she has all the qualities of an excellent and talented teacher. How appreciate her organizational capabilities, her vision, dedication, and meticulous efforts and hard work she puts in for bringing together such meaningful events under one banner of NIGF. Dr. Jyoti Malik, you add flavor to the team by your commitments, hard work, and attention to all the little details you put in, and that's quite evident in every aspect of your program. What we are starting today is the Dronacharya, and the word Dronacharya itself carries a profound meaning in our culture. It symbolizes the timeless bond between the teacher and the student. The commitment of excellence, discipline, dedication, and the responsibility of shaping the future generations. And sharing my experiences before I start my topic, it's not merely a personal recognition, but a tribute to every teacher, to every mentor, doctor, colleague, student, and patients who have been part of my journey. And how I look at being a doctor, as I reflect upon my professional life, I realize that medicine has given me much more than a career. It has given me purpose. It has given me content. I think it's gone somewhere. Wait a minute. Yeah. It has given me contentment of being the independent professionals, opportunity to learn, to do mentorship, counselor, and much more than that is it has given me, chance to be of some help to the society as well. Well, I was born in the beautiful valley of Srinagar when I grew up. My parents wanted me to become a doctor, and I was also inclined towards the profession. And I got into the GMC Srinagar on merit, and I did MBBS and MS Obstetrics Gynaecology from the same institution. So those days, our medical college was among the top 10 colleges in the country. Well, my journey in obstetrics and gynecology has been deeply meaningful. I'll tell you how. Because I had just joined as a house surgeon, and our hospital, known as Lalitith Hospital, was inaugurated by a legend, Dr. C.S. Dawn, in 1981. So colleagues of my age and my era would relate to what I'm saying. He was an authority on obstetrics. He was a legend, and then he had written many books also. And in his speech, he said about the role of an obstetrician and a gynecologist in the society. And that left a mark on my young mind. And the hospital that he inaugurated was a big hospital. It was basically 800 bedded hospital, one of its kind that was dedicated to women only. And it had just come up. And with this kind of facility, 800 bedded hospital for women only, we used to have almost 6,700 OPDs, around 150 admission, around 80 to 90 deliveries, and around 50 to 20 cesarean sections. And what the cesarean section would Oh, yeah, Dr. Ragini is there. I thought I had lost the connection. Yeah, I am able to see Dr. Ragini. Okay, now seeing so much of obstetrics, I have seen women going through hope, fear, pain, courage, and motherhood experiences, illnesses, complication, recoveries, and resilience. I was fortunate enough to learn obstetrics and gynae and practice almost every aspect of obstetrics. May it be external cephalic version, may it be craniotomy, instrumental deliveries like ventos, forceps delivery, rupture uterus, and APH, PPH, and these ectopic pregnancies, and medical disorders, and much more, and seeing lot of grand multiparous women and their complications. So that was the kind of exposure of obstetrics I got in early days. And those days, the government of India had also taken up family planning as a national issue. The program was also, it was named as Chitranjan Mobile Camp. I'm not very sure whether it was called Chitranjan Mobile. In Jammu Kashmir only, but it was all over, I'm not sure, but we would call it Chitranjan Mobile Camp. The government had provided us a very well-equipped Mercedes mobile ambulance with all the facilities. We would go to these camps in different districts to do hundreds of laparoscopy per day. Then laparoscopic ligations was the object. And it used to be so wonderful because there used to be festive atmosphere. And thankfully, J&K did not report any forcible ligations. Handling huge number of patients from all sections of the society made me compassionate. I learned to have patience and humility. I went for a regional level RCH orientation program, which Dr. Jyoti has already mentioned, and I imparted the training for AIDS and HIV control in the hospital as well as in field for more than 10 years. And that was very, very satisfying to train so many doctors and nurses. Along with this, I also worked as a counselor for adolescent-friendly reproductive and sexual health service since 2008 onwards for many years. Under this program, I, along with my team, imparted awareness programs to hundreds of adolescents in schools and colleges. Over the years, I had privilege for working in Government Medical College, Jammu as a teacher, as a clinician, and as a head of the department. Teaching young medical students and postgraduates, trainees, has been one of my most fulfilling aspects of my life. My growth as a professional has been multifaceted because those days we didn't have any super specialty concept in Jammu Medical College. I got an opportunity of doing all sorts of gynecological and obstetric surgeries, and that was quite rewarding. I was the first gynecologist from J&K to get basic as well as advanced training in laparoscopy and hysteroscopy, got trained from AIMS and Mumbai Beams and many more places, and helped in establishing the endoscopy section in the government setup, and started doing endoscopies, training people, and doing lots of conferences. And mind you, those days we didn't have a private sector in Jammu. That was nowhere it was done. Not even surgery department in our medical college had started doing laparoscopy. So we were the first ones to start. And maybe because we were very comfortable with doing laparoscopic ligations, it was very easy for us to start these laparoscopy. Then I was the first gynecologist from J&K to do TOT on SUIs. And I also did vaginoplasties. My forte was vaginoplasty with amnion graft. I did lots of them. I was very fortunate to learn it from Dr. Dal from Chandigarh. And then I used to do uteroplasties, especially Strassman. I used to do sling operations, and again was fortunate to assist Dr. Khanna because we know Khanna's sling operation, so that is the one I did first. And later I picked up many more methods. Then I used to do vulvectomies, I used to do VVF repair, and did lots of oncosurgery. While heading the department, I was instrumental in setting up ICU, HDU in the department, and help in implementation of the NRHM programs to pass on benefit to the poor. In 2013, with the start of functioning of AIMS Patna, Government of India appointed me as the member of governing body and continued as such for 8 years till 2021. I contributed to the highest level of institutional governance and strategic decision making. Besides, I was also a member of the recruitment committee and finance committee. I'm glad that I could contribute to the making of this National Institute into one of the finest healthcare facilities of the country. Now, taking up my clinical practices beyond textbooks. In fact, I also wanted to deviate from the traditional way of speaking on a specific topic and instead wanted to interact with you all on a broad-based experience and share with you some interesting and special professional encounters in my past. Projects on which I worked along with my team and postgraduates were numerous, but what I'm taking up today is some interesting studies and some unique cases I've dealt with. These are the cases many of you, especially the young ones, may have seen in books only. Now, starting with my first presentation. When I joined as a lecturer in Jammu in Medical College in 1922, I noticed that we were getting sizable number of carcinoma cervix patients in OPD. The trouble was most of them were stage 2, 3 and onwards. So those were the days when our professor, Dr. Kasturi Lal, a veteran in gynecological oncology, was working very hard in establishing the onco section in the department. So we were not even doing pap smears in the department those days. And much moreover, we used to get lots of patients with PID, with discharge, with foul-smelling discharge, and with all the symptoms of chronic PIDs and discharge. On speculum examination, many of them would have hungry-looking cervix and the bad cervical erosions. Keeping this in mind, I started a study on pattern of abnormal pap smear in 1,000 non-pregnant patients. It was a massive study. The observation of abnormal pap smear was highly significant and it got published later on. The study not only helped us in picking up lots of patients at an early stage, but also helped us to establish a screening program in the department, including mandatory speculum examination, visual exam inspections, and pap smear. Later on, we did add other stuff like colposcopy and much more. So you may find I'm talking about pap smear right now. It looks like prelim, but trust me, that was the time when we introduced pap smear in the department. It helped us in a massive way to pick up these carcinoma cervix at an early stage. So that was really very rewarding. Nowadays, we are doing everything, almost HPV, DNA testing, colposcopy, PapNet, polar probes are also there. So that was my first encounter, and I'm happy that I could contribute to cancer patients and to the department. Now, next in the queue is an original study that was done on pregnancy outcome in dwarfs. It was a case study of 5 achondroplasia patients. Out of 5 patients, 2 patients were admitted in the emergency as incomplete abortion. And obviously, DNC was done on them and evacuation was completed. And other 3 patients I saw in the OPD were in the 3rd trimester and referred from far-flung areas. One patient who was admitted in the emergency section delivered a preterm malformed baby at around 28 weeks. The second one came as an obstetric labor, again as an emergency case, and delivered a live baby by cesarean section. She was a great challenge to all of us and as well as for the anesthetist. Now, the third one was referred as achondroplasia patients with severe anemia and 34 weeks of gestation, and she was sent for the institutional delivery. Her gestational age was 34 weeks. Her hemoglobin was 6 grams. All the necessary investigations were done, formalities and other formalities were fulfilled. And she was given blood transfusion, and after building her up and bringing her up to 37 weeks, we did cesarean section and she delivered a healthy baby. The paper again was published in the International Journal of Gynae and Obstetrics. Well, in India, the birth prevalence of achondroplasia is estimated roughly in 1 in 15 to 40,000 live births. So here I am seeing 5 patients of achondroplasia. The pregnancy in the mother with dwarfism is exceptionally rare, and there are high-risk medical events. These pregnancies require multidisciplinary care to prevent severe respiratory and anesthetic complication. Now, what are the key issues? So let me bring in slides for that. Let me share my slides. So here I am talking about what are the key issues in these patients. The key issues are the medical risks, what is going to be the outcome of the mode of delivery, and what is the fetal outcome. The medical risks, we all know that they are short-statured patients. They have lots of medical disorders, and most of them have much more of hypertensive disorders and their complications, and PIH and its complication in pregnancy. The anesthetic management during surgery is critical because these patients have small chest wall, especially in pregnancy. We need highly skilled team of anesthesia to handle these patients. Now, what is the mode of delivery, outcome? Again, we know that they're short-statured patients. Their pelvises are small. They land up in CPD. They come with obstructed labor, and they have a very high cesarean section rate. Sorry. Now, about the fetal outcome, we know preterm births are quite common, and they need more of intensive care support. And they also have late onset of intrauterine growth restrictions. So we all know achondroplasia is an autosomal dominant disorder, and there is a possibility that fetus may also inherit skeletal dysplasias. Now, taking up my second case of the third one of the series is that in 2006, I got a patient in my OPD who came to the hospital with a hypovolemic shock as acute abdomen with history of amenorrhea 12 weeks. She was admitted, investigated, she was resuscitated, and ultrasound finding was huge peritoneum with no clear-cut source of hemoglobin. It revealed a suspicious mass near the right corn. After arranging blood, she was taken up for laparotomy. It turned out to be a catastrophic hemorrhage after rupture of the rudimentary horn in the pregnancy. The condition is rare. Its estimated range is from 1 in 10,000 to 1 in 40,000 as per International Journal of Medical Reviews and Case Report. Now, rudimentary horn pregnancy is a rare form of ectopic pregnancy, we all know, and has a high risk of rupturing typically in the second trimester. When the horn tears, it causes catastrophic intraperitoneal hemorrhage, leading to acute abdomen pain, hypovolemic shock, and severe maternal morbidity. Now, what is the pathology? So I'm going to come again to these slides. So the pathophysiology is the defect. A rudimentary horn is in the uterine malformation. It's a type of uniconvert. Yeah? Anybody is calling me? Yeah. So it's a uniconvert uterus where one side of the uterus does not develop fully. And in almost 85% of cases, horn does not communicate with the main uterine cavity. The rupture mechanism, what is it? Because rudimentary horn has a thick, poorly vascularized and less distensive muscular wall, it cannot accommodate a growing fetus. And the pregnancy loss occurs between 12 to 20 weeks of gestation. And what are the challenges? The challenges are misdiagnosis and the fatal outcome. Now, how this is misdiagnosed is that these patients come with hypovolemic shock, they come with pain, they come with acute abdomen, they generally land up at surgery department. But thankfully, our patient landed up in our department, and I feel pleased that it took us almost 1 hour to arrange blood for her and resuscitate her, and we did laparotomy on her, and we could save the patient. And we say fatal outcome is because this bleeds so profusely and give us very less time to resuscitate, and it's very tough to actually save these patients. And thankfully, we could do that. Now I'm taking the next one of my series. In my OPD, a young girl came to me with history of chronic and cyclical pain during periods, and the pain was also in the lower abdomen. On examination, I found obstructed distended hemivagina. No mass was felt per abdomen. I admitted her to for detailed investigations and management. While investigating, the patient, to my surprise, was diagnosed on MRI as a case of, it was a rare case of obstructed hemivagina and ipsilateral renal agenesis. The syndrome is called, let me bring in again my slides. The syndrome is called Overa syndrome, always and also named as Herlin-Warner-Wunderlich syndrome. Incidence of Overa is 1 in 20,000 live births, according to study published in International Journal of Surgery case report on May 2023. It's a rare congenital anomaly that affects the female reproductive and urinary system. And it is characterized by presence of septum that divides the vagina into 2 parts. One part is obstructed and the other part being normal. The condition often associated with the renal anomalies on the same side. Treatment typically includes surgical correction of the vaginal anomaly and management of the associated renal disorders. What I did was the resection of the obstructing vaginal septum with drainage of hematocolpus. The case was published in 2011 in the International Journal of Medical and Public Health. And this is how, on MRI, I could diagnose this patient. You can see here, so this is the hemivagina, which on PV I could see obstructed side, and this was the normal side, and the obstructed side, there is no renal system, almost missing. Here is the kidney, and so it's an ipsilateral, anomaly. So this was again very interesting. I found it very interesting, and it's one of the rare cases. Now, I'm going to take up the next one. This is a case of testicular feminizing syndrome, more accurately called androgen insensitivity syndrome, a rare genetic X-linked disorder where individuals have 46 chromosomes makeup. They are completely resistant to androgen due to mutation of the androgen receptors. The overall incidence of this syndrome in a phenotypic female is estimated between the range of 1 in 20,000 to 1 in 99,000 live births as reported by National Institute of Health. So here I am reporting this patient came to us when she was 17-year-old girl with history of primary amenorrhea. On examination, she was a tall girl, good-looking girl with well-developed breasts. They are well-developed breasts because of the aromatization of testosterone to the estrogen. On examination, I found little pubic hair, little axillary hair, and normal external genitalia and short blinded vagina. While examining the hernial site, well, you know what? I used to tell always my postgraduates, whenever you're seeing a patient of primary amenorrhea, you must examine the patient right from toe to head, including the hernial sites. So what happened when I was examining the hernial sites, I could palpate a small gonad-like structure in the inguinal region. And this is what I did the surgery on her. So what is the karyotyping of these patients? They reveal 46XY pattern. And what is the hormonal profile of these patients? They have normal testosterone range, they have elevated LH range, mildly elevated estradiol, and that's what she also showed. But there are some patients who are partial AIS with ambiguous genitalia, micropenis, hypospadias, and gynecomastia. My patient was a clear-cut case of AIS. So treatment, typically, wait. So what I did in this patient was that I had to do a little bit of counseling first. The little counseling, why you have to do the counseling of the patient as well as of the parents, because you have to make them understand that such patients, they are good looking females, they can live with the identity of the female. So what I did in this patient was I did gonadectomy on her, put her on HRT, and advised her to go back home and come back for vaginoplasty when she was ready to get married. So those days while I was doing vaginoplasties, so usually we would tell our patients to find some match who was a widower or with children, because that would give completeness to the family. So she came back after 3 years to me for the vaginoplasty, and I did amnion grafted vaginoplastic on her, which she was successful. It was successfully taken up, and she went home. Later, after 3 years, she came back to my OPD and told me that she had got married to a widower with 2 children. So I felt very good. I felt it was a kind of achievement for me that time. So next of the series, I'm taking a very, very unique patient of the series, and I'm going to present this. What happened that multiparous woman came with labor pains in the labor. On examination, she had normal vertex presentation, longitudinal lie, like a normal, fetal heart normal, and she was in early labor. After investigating her and waiting for her to go into full-fledged labor, we finally decided to accelerate her labor by oxytocin drip. She took more than the expected time to deliver the baby. Here is what she delivered. So, this is again a very, very rare condition. The baby survived for some time, tried to resuscitate it, but we could not save despite of all the efforts. It's a very rare congenital deformity known as cyreomelia, commonly known as mermaid syndrome, a syndrome where the baby is born with its legs partially or completely fused together, giving them appearance of a mermaid tail. It's often associated with severe abnormalities of the kidney, bladder, genital organs, lower spine, and digestive tract as well. Many affected infants have only one kidney or non-functional kidneys. So, you know what the incidence is? It is found in 1 in 60,000 to 1 in 1 lakh births. So it is that uncommon. So I was fortunate enough to see this patient, discuss this patient, and show it my postgraduates. And I'm happy to share with you this case. So the next one I'm going to show you is a patient of Turner syndrome who came to me in my OPD. She came with the history of primary amenorrhea, and she was a short-statured patient. And you can see she was short-statured, and there you can see she had a web neck and she had a broad Shields chest. And you can see widely spaced nipples in this patient. So that is very typical of Turner syndrome. On karyotyping, she was 46X, and ultrasonography depicted streak ovaries and a small uterus. After she got investigated, she went home, but we lost her. She never came back for the follow-up. Well, I did many more series, one on uterine didelphia, then vanishing twins, and much more. I don't think I'm going to take up that with you this time. And the only thing I would like to share with you one, interesting case, a study that was done on OGTT that was published and co-authored with me by one of my colleagues from the Faculty of Medicine, that is Dr. Jitendra Singh. He happens to be the Union Minister and PM office at this time. The journey through some of most unique and memorable patients challenged my knowledge, sharpened my skills, and most importantly, enriched me as a surgeon and as a teacher. Dr. Jyoti.
Hello.
Yeah.
Yeah, so ma'am, that was superb. I think that was actually beyond the books what we can ever see. We could see in the cases that you presented, achondroplasia and this O-Vera syndrome. These days, actually, with our ultrasounds and MRIs and with the knowledge now, more and more O-Vera cases we are seeing. But I was imagining your situation 25, 30 years back when it was never even thought of what it could be. So that is something which is so very interesting, that you have seen these cases when nobody knew about it, or the cases where on a lag cases of these fused lower limbs. So it was actually so very, I think for the people who have joined, it must have been a feast to our ears and eyes to at least see these cases. Maybe we would never ever see it in our lifetime personally, but at least through your presentation, we could understand them, and we could understand how a unicornate uterus rupture, how you handle it so very beautifully. So I think that was a wonderful presentation, ma'am. And if you could, now a few personal questions that I would like to go through. Why did you ever, what made you take the decision to be a doctor? And had you not been a doctor, any plan B you had in mind? Any other field of interest that you would have chosen? So if you could answer that for our viewers.
Yeah, sure, Dr. Jyoti. Before that, I would like to tell you, as you said rightly, these were the days 25, 30 years ago I have collected this series. Those days, there was no media, nothing available. We didn't have any Google or anything. Can you imagine, once we delivered a conjoined twin, and there was, the word spread all over in the labor room and in the medical college, Mata paida hogi, Mata paida hogi. Lots of people came to see. They started giving money to the mother. And exactly same kind kind of commotion was in the labor room when this mermaid was
This
developed,
baby was born.
when she was
Yeah.
delivered. So telling you frankly, I was a little bit, I felt very sad for the mother. And I was
Yes.
very happy being a doctor. I should have not said. I was very happy that we could not resuscitate this baby because she had no life. What could she have done
Yes.
after that? So that was
Yes.
the kind. So those were the days when we were not able to see all this. But still, I still find, because of now you have ultrasounds available, you are picking up all the disorders antenatally during ultrasound and all these tests. So there are less chances of seeing these patients now live. Yes, books we may have, but live these are less chances. Now, what question you asked was what made me a doctor? I think I said in the beginning, my parents
Yes.
wanted me to become a doctor, and I was also inclined towards this profession. But gynae, I told you in the beginning that Dr. C.S. Dawn, I don't know whether you know him or not, but he was a
Yes, yes,
veteran.
yes.
Yeah, he
We
had
have read
come.
his books, ma'am.
Yeah,
We
those
have
days I
been
used to.
following the books by Dr. C.S. Dawn, sir.
Yeah. So he had come to inaugurate our hospital. And you know what? Our hospital was the first hospital in India that was fully dedicated to women. And it was 800-bedded hospital. And Dr. Don, he, in his speech, told us about how obs and gynae can, these obstetricians and gynecologists can play a role in the society and how rewarding it is. So that left an impression on my mind, and I decided to become an obstetrician and a gynecologist.
That was, I think, a wonderful decision that you took, and so many hundred thousands of life you have been touching all throughout, and for a beautiful cause, I suppose. And any other thing you feel as a doctor, any other social responsibility that you feel we should be having towards our community, towards our women?
Okay. Yeah. You know what? Actually, my life is almost divided between the professional work and the social community life. I'll tell you how. Because, as I told you right from the beginning, I had this tendency of I had a feeling that we should give something to the community. That was somewhere in my mind. But then, whatever you say, whatever you think, it gets this pronounced also. That's how, it happens. So I feel the success is not measured by titles or awards and achievements only. Yes, achievements are important, definitely, but unless you touch lives, give confidence to people, build their confidence, give positive, you make a positive difference in life, in people. So that gives me a lot of satisfaction. And I think if you are able to do that, your success is complete. That is my personal opinion. And also, I always felt strongly that professional excellence must go hand in hand with the social responsibility. Professionally, I was very, very lucky that I could do in the early ages. I did almost everything in obstetrics. I did almost everything in the gynae, and I was quite satisfied with that. And then I landed up in a situation where I could do something for the community as well. And then away from classrooms and private practice, I was able to contribute to the community. I'll tell you how it started. My community witnessed a huge exodus in 1990. I don't know whether you people know. Those days, it wasn't that pronounced. People didn't know about it. But then when Kashmir file came, people came to know about the exodus of Kashmiri Hindus from in 1990. So due to the sudden eruption of terrorism in Kashmir, to help the community, because I was in Jammu only, I started doing free camps for them in those camps. And for many years, many of my community members, we all got together and we were doing camps, health camps. But later on, ultimately, with donations and with the help of the government, we helped in making up a multidisciplinary hospital named Vitasta. And I was the trustee and of one of the management person there, and I was fortunate enough to play a major role in this venture. So that is one I feel good that I could do something for my community. And then it's very interesting. I worked with some NGOs, Red Cross, various eminent bodies to address the social responsibility. But my journey was something, it was both mix of pleasure and struggle. Now, how do you say pleasure? Because I love my subject. I enjoy doing obstetrics. I have done everything because I never used to get, with God's grace, stuck up with anything because I had everything done hands-on. So with God's blessing, and then as a senior also, I did almost everything. So that's why it gave me a lot of pleasure to me. But what kind of struggle did I have? Because I happened to be married to an IPS officer. Hold on. That was not the struggle. just because I was happily married and I'm still happily married. So what happened those days in 1989, terrorism erupted suddenly. And since my husband was at the helm of affairs dealing directly with the militancy, right? And me and my family lived under the shadow of militancy and threat. That was very disturbing and depressing. My husband, after huge contribution in eradicating terrorism, completed his career as a Director of General of Police in J&K and headed the force for 5 years that time. Incidentally, this situation, and why am I talking about this, is because this situation, incidentally, gave me the opportunity to be in the center of the cause of the social service. I headed Police Welfare Association as a chairperson for 5 years, and that was not an associate for the sake of get together or pleasures, but was meant to do serious work to look after the families of police welfare forces, particularly families of martyrs. And the martyrs who had laid down their lives for more than, for more than 2,000 police martyrs for the integrity of the country. So it was a huge job. And let me see this up. And we created lots of jobs for the wives and ensured that ex gratia money that was huge in amount reached the martyrs and their families. And I was fortunate enough to get opportunity to work closely with the J&K police from 2007 to 2012. This provided me a unique opportunity to contribute to the welfare of these families. We had lots of schools there, the high schools, high secondary schools, middle class schools, and they were with the welfare centers. So a lot of work I did there, the modernization of these. So few pictures I would like to share. So this is where I'm doing some inauguration. Mr. Kumar, I can't see anyone there.
Yes, ma'am.
I can't see anyone there in the
No, ma'am. Everyone is here.
Okay. I don't know, something happened to so I thought it was good. Okay, yeah. Thank you. Wait a minute. Let me share my pictures. So इसको minimize कैसे करूं?
मैम यहाँ ये आई के जस्ट बगल में मिनिमाइज का एक
I
ऑप्शन है.
can't see it. Wait a minute. I want to show my. ये छोटा करना. Anyway, I'll see. It's okay. So what's happening to this? Yeah. So those were the days when I was doing a lot of work with, this was the wife of the chief minister, and the chief minister, me and his wife. And then this was the governor and the lady governor. We were doing some work there. And these were the kind of melas we would actually arrange those days. and raised a lot of money to do the welfare work. And then these were the kind of rewards would give during melas. And that's me with the President of India, and that's again with President of India, and that is the hospital I was talking about, the Vitasta Hospital, which we created. And that is, I was fortunate enough to meet ex-Prime Minister Mr. Manmohan Singh and his wife. So again with Mr. Manmohan Singh and his wife, and doing some school work. And this was with the governor, some inauguration again. This was when, we started AIMS Patna. So that time the cabinet minister, Dr. Azad, and me and his wife in the picture. And this is again some inauguration. So this is with the lady governor. Incidentally, this lady, she was also an IAS officer. I had lots of projects with her. I did a lot of work with her, and I learned a lot from her. Some serious discussion with the governor, and that's me, my family, and me. Over to you, Jyoti. Yeah, Dr. Jyoti?
Jyoti ma'am, hello.
Yeah, so I think we really enjoyed listening to you, ma'am. And you are such an aspiration for so many of us. Now that we know you much, much better, and we know you more as a person, as a clinician, as an academician, as a socialist, as a woman of substance. So I think you really have given us so many insights into what a woman can do as such, and as a doctor, as a on her personal front, on her professional front. You have really done so much for us to aspire from. So thank you so much for your time, ma'am. And I'm sure all the youngsters who have been logging today or who would go through this, we have this being recorded, and this we will give in a week's time on the same platform. So whoever could not join us today, again, they can sort of go through and revisit your this presentation, ma'am. So thank you so much, ma'am. Thank you for your time. And I would like to thank Sharda Jan, ma'am, our patron, Dr. Ragini, ma'am, our president, and the complete team of NIGF, who has been always doing such wonderful things to make people more aware, both scientifically, clinically, and professionally. And this particular sort of Dronacharya is more of a combo of both the things. We learn also, and we learn from your personal growth as well. So thank you so much, ma'am. It was pleasure.
Thank you, Dr. Jyoti, and pass on my thanks to Dr. Ragini also for having me on the
Sure,
platform.
ma'am.
Thank you, everyone.
Sure.
Okay, all the best.
Sure. Thank you so much.
Thank you.
Roshan ji, I think we can just Dr. Manju Verma, ma'am, is there.
Yeah.
Ma'am ne bola hai there. It is an excellent talk.
Hope you guys enjoyed it. I'm not sure. I don't know how you liked it, but I love this because this is like my collection. Because I used to show it to my postgraduate. Every batch would come and please show us these, ma'am. That's okay. I have a huge collection, but I just picked up here because I wanted, it was 1 hour total. I had to cover everything. And then I wanted the other aspect I have never shown to anyone. So this time I shared the other aspect of my life with you guys. So it became little interesting. So a little हटके जो करते हैं रोज उससे थोड़ा हटके था.
जी. Thank you, ma'am. Thank you so much.
Thank you.
Roshan ji, we can close the session.
Okay,
Thank you.
Thank you, ma'am.
Thank you.
Okay, thank you.